Neonatal resuscitation. Neonatal resuscitation is required at labor room to help a newborn to make the respiratory and circulatory transition more effective. Normally a newborn gasps by 6 seconds, and if not, majority of them do so by 30 seconds or 20 seconds. And as soon as a newborn gasps, the lungs get expanded, filled with the air, the pulmonary blood flow increases, pressure in the left atrium rises, closes the foramen ovale, ductus arteriosus closes at the same time, and there's an independent circulation and respiration is established. But if due to any reason the newborn is hypoxic, either due to a maternal cause or a fetal cause or a placental cause, then he will manifest this hypoxia in the form of apnea. And that apneic child thus requires neonatal resuscitation to establish an independent state of respiration and circulation. The first step is to be done in every neonate, whether he requires neonatal resuscitation or not. This is done in first 30 seconds. You prevent hypothermia by providing an overhead warmer. You correctly position the baby, dry him with the cotton sheets, clean the baby, rub him, and as you are doing this rubbing and cleaning, you are stimulating the baby, and this mere rubbing and cleaning will provide enough stimulation for the baby to get his own respiration and circulation. But if the baby doesn't get his own respiration and circulation by simply rubbing and cleaning and stimulation, then you have to go for actual steps of resuscitation. And the indications for further steps, that is the criteria by which we know that now we have to go for resuscitation, are three things. If any of these is abnormal, then you will go for resuscitation. You look for the cry of the baby, whether it is normal or abnormal, whether he is crying or not crying at all. Then you will go for the color of the baby, whether he is cyanosed or pink. And thirdly, you will look for the heart rate of the baby. The heart rate of greater than 100 per minute is normal after the birth. But if it is somewhere between 60 to 100 and it's not increasing, then that is an alarming sign to go for resuscitation. This slide contains all the steps we do in the neonatal resuscitation, and the next slides we will just elaborate these steps one by one. So the management basically consists of A, B and C to maintain the airway, breathing and circulation of the baby. The airway are to be cleared up by suctioning. The breathing is maintained by supplying a positive pressure ventilation, and this positive pressure ventilation is initially supplied by bag and mask and later on by endotracheal intubation if bag and mask is not effective. Third thing is to maintain the circulation of the baby. And this circulation is maintained by chest compression initially, and when this chest compression is not effective or not successful, then we supply the epinephrine. The first thing, suctioning, that is to clear the airways. There are a few things which we keep in mind while doing suctioning. The first is to never go for blind suctioning in a neonate. Why? Because blind suctioning creates a very high negative pressure, and as you cannot see the airways directly, it can perforate the airways, and that perforated airway can act as a portal of entry of infection in the future. Secondly, if you do stimulate the posterior pharyngeal wall while doing the suctioning, then that can stimulate the vagus nerve and the baby can go into cardiopulmonary arrest. So the ideal way is to do the suctioning with the help of direct laryngoscope. You visualize the airway by direct laryngoscope and then do the suctioning. If at all you have to do blind suctioning, then use suction bulb instead of the catheter, because that suction bulb creates slightly less negative pressure as compared to the catheter. The second thing which was to be maintained was breathing. Breathing was being maintained by positive pressure ventilation. This positive pressure ventilation is initially supplied by bag and mask. The area covered by the face covered by the mask is very important. It should ideally cover your nose and mouth area, the lips and the perioral area. It should not be hanging downward from the chin, and it should not be touching the eyes. The rate at which you supply the puffs is 40 per minute, and initially you supply a pressure of 30 to 40 centimeter of water and later on 15 to 20 centimeter of water, and you give this bag and mask ventilation for 30 seconds and you observe whether the baby has gained respiration or not. If after 30 seconds of respiration the baby has not gained, after 30 seconds of positive pressure ventilation by the bag and mask, the baby has not gained respiration, then you will go for endotracheal intubation. And the specific indications for this endotracheal intubation are if, as we talked, in the bag and mask ventilation is ineffective, or you have to provide this positive pressure ventilation for a longer time, or the baby is a suspect of diaphragmatic hernia, or there is a history of meconium aspiration, or the baby is a preterm infant and he is ultimately going to require assisted ventilation, then you will go for endotracheal intubation. Out of these, the diaphragmatic hernia and the meconium aspiration, these two are contraindications of bag and mask. If the baby has these two, you will not do bag and mask even for the first time. The third thing was to maintain the circulation of the baby, and that was the parameter for measuring the circulation of the baby was heart rate. So if the heart rate is less than 100, then the first thing you do is chest compression. You hold the baby in your hands with the fingers at the dorsum of the baby and the thumbs meeting in front at the chest. You compress the chest at the level of sternum at the junction of upper 2/3 and lower 1/3 of the sternum, and you compress it at a depth of 1/3 of the AP diameter of the chest. That is, when you are compressing it up to 1/3 of the AP diameter of the chest. And as you are maintaining the respiration and circulation side by side, the ratio of chest compression to embo bag is important. The ratio is 3:1. So you do the chest compression as 1, 2, 3 embo. You do, and then after 3 compressions you give 1 puff of embo, and then 3 compression and 1 puff of embo, and you observe for 30 seconds. If after 30 seconds of chest compression and doing all those resuscitation efforts, the heart rate is still not maintained, it's still 0 or less than 80 per minute, the peripheral pulses are still weak and the baby is still showing the signs of poor perfusion, you will go for adrenaline. And the strength is 1:10,000, and the dose is 0.1 to 0.3 ml per kg. You can give it IV or intratracheal. The important thing here is that the baby is going in a state of shock. So he has poor peripheral pulses, poor perfusion, the vessels are collapsed. So it's very difficult to find a vein where adrenaline can be injected. So the ideal place in this situation is umbilical vein, because you can find it easily. And the next important question is to identify the umbilical vein. If you are standing at the foot end of the baby, then the thing at 11 o'clock position of the umbilical cord will be umbilical vein. It will have a thin wall as compared to the artery, and it will have a larger diameter as compared to the artery. So in this way you recognize the umbilical vein, you put the umbilical catheter in it, and you give all the fluids, medications, including the adrenaline, whatever you are going to give in this resuscitation through this umbilical vein. The last thing is to think about other medication which may be required in neonatal resuscitation. Number 1 is volume expanders. These volume expanders are required if the baby is still showing the signs of shock, like poor perfusion, poor peripheral pulses, or weak pulses despite having a good heart. Then you will go for these volume expanders, and these are normal saline or ringer's lactate or 5% albumin. The dose is 10 ml per kg IV in 5 to 10 minutes. The other thing which you can do is to give sodium bicarbonate to the baby. This is done also in case of prolonged cardiac arrest or prolonged metabolic acidosis. Normally the metabolic acidosis gets settled after the respiration is maintained by positive pressure ventilation, but if the acidosis is prolonged or there is prolonged cardiac arrest, then you give sodium bicarbonate 1 to 2 milliequivalents per kg IV, slow diluted over 2 minutes. Third thing which you can give to the baby is naloxone hydrochloride, and the specific indication for naloxone hydrochloride is a history of maternal narcotic administration within past 4 hours. And the dose is 0.1 milligram per kg, IV, IM, subcutaneous, through endotracheal tube. You can give it through any of these routes. And the last thing here is dopamine, and this is given as 5 to 20 milligram per kilogram per minute continuous infusion only when After the prolonged resuscitation, the infant still shows poor peripheral pulses, poor perfusion, and continues to show the evidence of shock. This is given only then. And that's it.